So, I guess with just a lot of stuff that we've been seeing on social media, it's kind of become like the more popular way to go about things, and you get more clicks and more followers by taking this approach where, okay, you have this type of pain, well, do these two things and you'll be better. Or I can fix that, or bulletproof this, or, you know, um, it seems like it's probably feeding into that narrative of patient expectations that just aren't realistic. And I've seen a number of people say this, and I think I might have seen it in a publication where they said a lot of these like really unrealistic patient expectations are really just coming from the practitioners. It's not coming, like, everything we read on the internet, everything we hear isn't from some random person's opinion. It's really all been started by us. Is that not a kind of a problem?
I had this conversation with a couple people online this week that if we actually, a couple guys, like Lee Schneider's a PhD candidate out of Australia. I was talking to him, and if you look at the data over like the past 30 years, and you look at like the increased utilization rates in both physical therapy and in chiropractic, like there's increased rates, right? So people are going to seek healthcare more, but the burden of back pain is growing, like on the verge of being exponential. So if you want to take this corollary statistics look, if you look at the data, we are making people worse. That is what the data shows us. The data shows us is that the profession of musculoskeletal care, in its endless pursuit of bulletproofing backs, is actually making people live with more pain and more burden of disability, which is really the biggest impact. Not to diminish pain, but the incapacity to live your life. That's wild.
It's really hard to accept for practitioners too, because I actually said that when I was talking to somebody just a couple of days ago, and the response was very much like, well, that doesn't mean anything. So, I mean, I'd agree with you that there's this trend that everybody's starting like using this a lot more, and all of these MSK issues are like on the rise.
So yeah, anyways, I think that mainly probably happening to a degree too is people can prioritize this a bit more. They can prioritize their conservative care. They can prioritize their MSK health a bit more, since you don't have the same issues that might have been prevalent 50 to 100 years ago. That being said, it also comes into the idea: is it remixing?
Yeah.
Okay, what do you guys want me to do? Because this is gonna work.
I want you to keep going. I want you to tell me about how we're prioritizing musculoskeletal care more now that we have less polio.
I will cut some of that
Yeah.
out.
Yeah, Dave
So
will go
anyways,
to
we're
After
basically
Effects and cut out all the parts where it
okay.
remixes.
I got my
Okay,
work cut
can
out for me.
someone like give me like a thumb? Can someone give me like a signal if it starts remixing so I know?
Well, everyone's gonna see it.
Well, I can't see it, right? So I don't know if I'm talking.
Yeah, so anyways, I was going to just lead off with what Dave said, the idea that I feel like a lot of the issues we have nowadays maybe wouldn't have been as prioritized back maybe 50 to 100 years ago when we had more communicable diseases and the likes of that type of stuff going on. Probably also why nowadays we get that pushback thinking more essential care during pandemic, because there's almost this relative aspect of thinking MSK is such precedence, even in a time when there's a very infectious disease going around.
Yeah, that's probably a very good point. Like if you're less concerned with getting like measles and rubella, you're probably your concern for back pain is a lot smaller when your quality of life is dramatically different, because like a crisp cold at the age of 50 could knock you out. So it's I mean, how much does that still kind of lead us to the fact that someone comes in with like just general back pain now, and we're like, yeah, there's a problem to be fixed here. Like, we need to fix this back pain.
That's like my grandfather used to say, my back's a little sore, but at least I don't have polio.
Yeah. Like, actually, I guess, sorry, this one always reminds me of this, is because we're talking about diseases, but if someone gets like 3 colds in a season, like if you get the cold 3 separate times in the season, it's like 3 separate moments of illness, right? If you get like 3 episodes of back pain in a year, you have like a broken back now. Like, why do we have this assumption that it's my back that I've just thrown out again that needs to be fixed. It's like we have no way of determining if it's the same reason that you're experiencing that back pain. And anyone who tells you that they do is probably lying to you.
Yeah, we literally have no certainty with our diagnostic abilities in most cases, right? If there's like that true pathoanatomical reason within that like 10 to 15%, that might even be a bit big of a number. You know, we could probably pinpoint something a little bit more specifically there, but in like, you know, 90% of the cases where it's just non-specific, where it could be a muscle, or it could be a joint, or it could be a nerve, or it could be anything, like there's no way in us to be able to be confident just because we did like 4 orthopedic tests that if you use all 4 of them together, it'll probably mean one thing versus another, right? Like I still don't think we can even be specific with that. So, and I was listening to Oliver Thompson talk about this, where he said, so we can't even be specific, but if we were to be specific on a tissue, none of our manual therapies are specific. They're all just very broad things, you know? If you do a manipulation on somebody, you're stretching a bunch of muscles, you're moving like...
Are we though? Are we stretching?
With that, okay, like I'm just saying like what the argument would be, right? What the argument would be for a manip, you're apparently like you're getting joints, you're moving the person. You're literally taking somebody and twisting their entire body, and like almost every tissue there is going to be affected. So we can't be specific on that. So like why even force that and say you have this so I can fix this by this?
Even better than that is the fact that if they did have a structural pathology, nothing we could even do realistically is going to change that structure from a conservative standpoint. So if that was the case, we would be out of a job because we can't do anything. Secondly, if it was a fix-it problem, then we would probably see a lot better research for specific rehab plans compared to non-specific. And even for things like knee conditions, which I've always considered basically the precedence for, I got to have the most specific rehab plan for this knee condition, which is this knee condition. Even then, they're finding that non-specific rehab tends to perform just as good, showing that maybe it isn't just biomechanics, it's not just physics. You got to take into account it's a living organism that may benefit from movement and the other benefits that come along with that. So,
yeah, this over medicalization, going back to the burden of healthcare that Ben was talking about. I was reading a few publications. I am not Ben, so I don't have the publication authored right off the top of my head. But it was talking about how the over medicalization is in part what is perpetuating this the burden of low back pain. Now, if low back pain is very common, like upwards of 80% of people will experience back pain. It's common enough that it's almost like the common cold, where almost everyone gets a cold. Now, what do we do when you have a cold? Well, we know it's going to get better generally in 7 to 10 days. So you might go to see the pharmacist and pick up some decongestants and some medication that will help to manage some symptoms. Try to live your life, maybe rest a little bit, live your life as you were, and then go and just let it run its course and it will get better. If we treat acute low back pain, we know that acute low back pain will resolve, and we know that if we treat it in a similar way, like it's going to get better, we can expect it to get better. Instead of going to see the pharmacist, you could go see the pharmacist and pick up some pain relieving medication if you feel like that helps. You could go see a chiropractor or a physical therapist for some symptom management in the early stages. Keep living your life, maybe rest a little bit if you need to, and it's going to run its course and it's going to get better in a matter of weeks. If we take this approach to low back pain, just like we would the common cold, the people's expectation that it's just another thing that gets better rather than something is broken and something needs fixing, then it certainly increases our expectation to get better. But I think that one of the reasons why this fix-it mentality is so prevalent, especially among practitioners, is because practitioner wants to fix something. They want people coming into their clinic more frequently and more often. Maybe this is just because I'm cynical, but maybe there's some truth in it, that we're trying to profit off a condition. And I'm not saying that chiropractors, physical therapists, anyone don't have benefit, and people can't benefit from treatment and from the process, but probably we're utilizing it too much.
Yeah, I think it's important to fall into the realization that what we're doing is still okay. Like you said, we're managing symptoms in the early going if the person needs that, trying to modulate pain. But like we can still do something, because whenever we say, you know, we're not fixing anything, then sometimes people can get defensive and say, well, what am I doing then? Like I can't just sit there and educate someone for a full appointment. I mean, you could, because some people will respond to that. But the education is just letting them understand exactly what you guys just said. Like this is going to get better over time. You don't have to worry that this is some really bad thing that's going to keep happening. You don't have to worry that you're weak. So just giving them tools to understand what's going on with them and then what they can do about it, giving them a few movement based, like just an exercise or something that they can do to help with that pain if it happens again. That's what we're doing. And then, yeah, we can do a little bit of passive therapy if we feel like they would respond to it to help them keep living their life in that moment. But I forget the name of the fallacy that you said, the sunk cost fallacy.
Yeah,
Is that it?
sunk cost fallacy is a
I
big
think
one.
that's what's happening a lot, because we've all spent like a ridiculous amount of time in school and a ridiculous amount of money into this thing where the general premise and what we thought was we're fixing people. And when you finally realize that that's not at all what we're doing, it's really hard to come to that terms and be like, well, I didn't put all this time into it. I didn't spend all this money just to sit down and educate someone and give them some exercises and maybe do a little bit of soft tissue or something like that here and there, right? People don't like that. And I think that's probably driving it too.
Yeah, I mean, I think you guys all read this one too, but there's that paper that came out last week, right? That Manchurian candidate, chiropractors as propagators of neoliberalism in healthcare. I don't have in-depth philosophy knowledge, and my political philosophy is even less. So my understanding of interpretation of neoliberalism in healthcare is low, very low. But the article points out kind of exactly what you guys are saying. It talked about it's also medical doctors chiming in, which again I do value what people that go through the medical education process have to go through to interpret and understand how to help people in a wide variety of ways. But anyway, they dive into the fact that yeah, we've taken healthcare and we've completely driven it into a for-profit system, which occurs in the American health medical care system, like very obviously, right? But in Canada here for us, like our like chiropractic and is a private insurance-based care. You're either paying out of pocket, or you have limited benefits that or insurance that covers it. So, like you were saying, Elliot, if this is going to be a course of thing, if this is going to be a 2-week condition, and someone has $500 of insurance, like he's going to get better. The person's going to get better in 2 weeks. Like, do we need to? How do we justify 6 treatments for that? Because that's what we're taught, and that's what you see when you ask people, what do they do for an instance of low back pain? 6 visits over 2 weeks. Like that person's going to that person's a coin flip chance of having their back pain resolved.
Not,
Your 6 treatments didn't do that, right?
yeah. Not
Just
only,
it might have made them feel a little bit better in the short term, but then you got to look at the financial cost for that.
Yeah.
Well, the other thing too is the fact that maybe over those 2 weeks they feel like they've gained a bit of control back in their life and they're actually actively participating and getting themselves better. But then after those 2 weeks, now they're in this mindset where, oh, I need this clinician or I need this professional every time this happens, or I better keep going to them or else it's going to come back. So maybe it has a short-term band-aid effect of thinking that they're now in a protective state by seeing that clinician. But you also then build this mindset and basically behavioral pattern of making them feel like they need this clinician every time it happens.
mm-hmm.
So this is where I wanted to go with this talk, where we're this is how much our language that we use as practitioners is so important, because yes, in the short term, maybe 6 visits, the research doesn't line up with that, but 2 to 4 visits, maybe over the first few weeks, typically not really much more than 4, people can have really good benefit from that. But we need to watch what we're telling the patients. We need to watch what are they coming out of? Are they coming out of this treatment experience thinking that there's something broken that needs to be prevented and that needs to be fixed? Or are they aware of the actual nature? Are they aware that, yeah, it might come back, but it's nothing structural. It can be managed on its own. Do not necessarily need to come in. If they want to come in the office for treatment because they feel like it helps, that's entirely their prerogative. There's nothing wrong with that. But if we are perpetuating this idea that this fix-it mentality that the patient is broken, well, we are negatively affecting the patient's mindset and in turn their outcomes. So like this is the a really good segue into a recent paper, Beals, Slater, Paulson, and O'Sullivan. It was just published matter of days ago, really. When was this published, Ben?
Pre-published 2 weeks ago, and then online published like 10 days ago, and then it's actually like it'll be in print in like August, or July or August.
So this is like not even hot off the press. It hasn't even made it to the press yet, but because we live in the future, we already have this information, kind of like research time travel, and that's pretty cool. That's called Understanding and Managing Pelvic Girdle Pain from a Person-Centered Biopsychosocial Perspective. And this really gets into how we can tie in what we do with our hands with what we do with our communication, what we are telling the patients so we can optimize their outcomes and educating them appropriately. So we're going to summarize this. We're going to break down what their recommendations are and how we can kind of change. We don't have to change what we do, but we just change what we say. And with that, we can improve patient outcomes immensely.
Yeah. So I hunted this paper down as soon as I saw that it came out the day of, because every author on it has been doing this and purposefully and intentfully to look at this kind of thing. And Peter O'Sullivan's probably one of my favorite researchers, and then Paulson has put out a couple papers in the last few years that I think we can all agree on have touched on things that need to be addressed in the profession. So the first thing that I found very interesting that they hit off right at the bat is they just get into what is appropriate and what's inappropriate in language with your patients coming in with like pelvic girdle pain. So pelvic girdle pain can be like lower back SI pain. It can be pelvic floor pain. So it's kind of a generalized area. So they do address that later. But the things that they talk about right away, which I know we all hate, are things like your pelvis is unstable, or your pelvis alignment's out, or your pelvis even can go out, or things like even like a weak core is causing your pelvic pain. All that is wildly incorrect, like so far from the truth, and yet it's things that I think we've all heard people either tell us, we've heard other practitioners tell people. Like, how often do we get taught, or do we hear like, well, if the pelvis is rotated or upslipped or things like that?
Yeah. So like it's these things are not founded in research. They are purely anecdotal based off of what people think they feel in unreliable palpation tests. And as for joint displacement, because Dave is going to edit this, he's going to put in a picture that you can see right now in the video of a pelvis fracture. This is someone was in a car accident and their pelvis was fractured in half. You can see there's a huge fracture line right through the middle of the pelvis. But if you look closely at those SI joints and those pelvic joints, the joints of the pelvis that do move, very tiny amount, but they do move, they are still there. They are still intact. Like, these joints and this pelvis is such a strong structure that if you obliterate the entire thing by breaking it in half in a car accident, the joints are still there and they are still intact and they haven't budged. So let that sink in. We'll get back to it then.
So I was going to say one thing, and I think Dave can also speak to it because we're in my same technique class. But, the whole idea of like Gillet's testing and measuring the SI joint and seeing how much it's moving. But then I'll use traditional therapists or traditional chiropractors that claim, well, we have nothing better. Well, realistically, if you want to look at it from a mechanical point of we have nothing better to use our hands with to measure degrees of motion, maybe, but we do have better when it comes to looking at the person as a whole person and looking at the whole picture, which is the biopsychosocial model again, and looking at the idea that, yeah, the research isn't following this, so maybe it's not the best idea to go through with this. So I just want to leave with that idea that what Elliot's saying is, yeah, it's not really going to move if it's structurally stable. And the whole idea and argument that, well, we have nothing better, yeah, maybe if you're tunnel vision and only looking at it from one perspective.
Yeah. I think, like, do we even need anything better? Like you just said it, just look at the person, understand what isn't feeling good and what might make it feel better, and then just approach that based off of what they can do. We don't need to move anything around. We don't need to feel if something's moving or not. We don't even really need to feel if some muscles are tighter than the others, because one, we don't know that. We're biased when we're feeling that, even from side to side. There's research out there that says we aren't even good at um, finding areas of stiffness when we're palpating, because it's actually just a perception thing from the patient. So, we can't even say what we're feeling is necessarily what's going on. So why do we have to do that? Exactly what you said. Just look at them as a whole.
Yeah, and we look at chiropractors and physiotherapists when they go through when we go through school. They are trained. Well, we're gonna do some manual therapy. We're gonna give them some exercises to do so that they can get moving, and we can do some therapy to help them feel better. You don't have to change what you do. You just have to change what you say and how you are educating the patient. So one of us was having this discussion with a older clinician who was saying, well, if I don't have an SI adjustment, what do I have? Well, you have an SI adjustment. We're not saying don't do that, because patients still find it beneficial, just not for the reasons you think. And you can probably help that patient get better faster and have overall better quality of life if you educate them on what's actually going on, rather than telling them that we're moving this joint because it's out of place.
The only thing I'd like to maybe say in comparison to that is the idea that we had this discussion, but patient preference for adjustments are generally dictated by clinical judgment and recommendations. Like no one goes, like, is bored or wakes up and thinks, oh, I really need to get my back back. These are things that are propagated from the profession and make people believe these things, which then the patients then think, well, if they say this, then it must be good for me. And so I agree that if the patient believes these things, then we should probably help them to a degree, maybe help them educate them, and we can perform these things. At the same point, like the idea that patient preference dictates everything, when most likely it's a bit more of a feedback loop of the clinician telling them that these things are good for them, and then slowly they propagate these things. I think it may be better off just biting the bullet there, so to speak.
Can I just take that ball and run with it for a second?
Yes, Dave, give us all your deepest, darkest thoughts on this matter.
Well, just to run off of what you said, when we look at the evidence-based approach, we were taught that it's 3 pillars. And I think people take that the complete wrong way and think that each of the pillars is just as important as the other. And we've seen some people talk about how it's more of a funnel. And I'm not discounting patient preference. I'm not discounting clinical experience, but each of those sort of concepts should not kind of overpower the general base of knowledge that we have. So we have this big pool of evidence that says, these are what we should probably do at this time. And if there are holes in that pool of evidence, then it's okay to think outside the box and try and see what's kind of been working for you as a practitioner. But you can't just go and make something up and use that, well, the evidence doesn't support this, therefore my clinical experience is more important, so I'm just going to throw out all the evidence. You got to take the evidence and use that to base your clinical experience and kind of put those two things together to kind of make a little bit more sense of things and to give your treatment a little bit more direction. And then the same thing with patient preference. Ben said this the other day. If somebody's coming in with a tendinopathy, like an active or a reactive tendon, and they say they like acupuncture, I mean, we're not going to stick a needle into a reactive tendon just because they said they like it, right? Because we know that that's going to do more harm than not. So again, we can't just say, well, patient preference, I'm just going to do what they want. It's a team effort. So they definitely tell us what they prefer, but then also from us, from a practitioner standpoint, we know enough to say that maybe this isn't the time for that. But if it is, and it's not going to hurt anything, sure, we'll try it.
Yeah, that's like, and that's what the authors in this paper come with too. And it's one of the points that I really liked is that they talk a lot about meeting the patient halfway. And I know that this is something that I, and probably all of us have struggled with at some point, is that like a patient comes in and they say something and you're like, oh wow, that's like so far from the truth. They come in and they're like, yeah, like my right hip it's all twisted up, like it's way hiked up, like I need you to take care of that. And if you just flat out tell them, like, no, it's not. Like they're not going to connect with that very well, right? So you kind of have to,
out the door.
yeah, you told them that they're wrong, like yeah, they're done. So you have to like kind of to work to them to get a middle ground and like acknowledge that what they're experiencing is real, and acknowledging what their experience is, like how they are perceiving that, right? Like there's like you said before, Dave, like how we perceive their stiffness and their tightness is not how they perceive their stiffness and their tightness. And if we did our opinion on it, and they did their opinion, and then we did an objective measurement, like we could all be wrong, right? We could be nowhere near each other. And we've seen that in data too. I think Mosley and Kachuk did some, or not, sorry, Stanton and Kachuk run that one, right? Yeah. Okay. Yeah. Small cast there. So I think that's really important, and the authors highlight that too, right? So we don't want to dismiss people's feelings and their sentiments towards what they're experiencing, but we do have to guide them, right? So you can be like, okay, and then you can, like, how can you show them that their hip isn't doing that instead of just telling them that their hip isn't doing that, right? Or their pelvis is out of alignment. And I like that point a lot. At the same time, like this paper is really interesting, and along the same lines is it talks about that Laslitz SI joint testing, which we all get taught as like the gold standard for what's SI joint testing. Like we know that if we have 3 out of 5, you're pretty certain that this is what's going on. Or and then if you get more and more, the odds go down that it's specifically that. But one thing that this paper points out that I love to talk about is that those tests, which are good, only tell us that there's pain coming from the area, that this area is sensitized. It doesn't tell us what is causing the pain. And I think we misconstrue that concept a lot in our education and in our practice, right? Like if I do 3 tests on the SI joint and all 3 are like, yeah, that's uncomfortable, that's that same pain I'm getting. Like you just know that general area is uncomfortable.
You know what their experience is with that pain location. You don't know the structures and the mechanics behind why it might be occurring, or if there's even a mechanical reason.
Yeah, like I think
things are sensitive. But that brings up the point of like a different orthopedic test where we have a pain provocative test where you are producing pain. That's really useful information because it's telling you that hurts. So you can build that into a plan that is focused around the patient and their pain experience. But if you're doing a test that is not based off of pain provocation and you are looking for something that's subjective. So it's different to have like an anterior drawer test if you're looking for an ACL tear. You pull that tibia right off the femur and it's sitting out there and it's measurably out. That's pretty objective. That ACL might be torn. But you would think that would be painful, but it might not be painful, right? But if you're doing something like, oh, I'm gonna measure and feel how your SI joints are moving, well, they're definitely not doing this. Definitely not doing a J motion. That's entirely subjective. We know that test isn't useful. It doesn't give us a reliable measure. And it doesn't even tell us the patient's experience with pain because it's not a painful thing, right? So, I mean, we look at any orthopedic test, the sensitivity and specificity of orthopedic tests aren't really that high to arrive at a structural diagnosis. So we can't say that, like if someone is doing like the Kemp's test where it's extension and rotation of the lumbar spine, and they say that hurts. Does that mean that they have a posterior joint, a facet joint inflammation or irritation? No, we can't say that for sure. But it does give us pretty clear information that extension and rotation with load hurts. So we can build that into a plan.
Yeah, like yeah, go ahead, Dave.
That's a really good point, though, because we were usually taught in school to not focus so much on pain, but I think what you say makes complete sense, and we have to get those subjective responses from a patient to understand how we're going to manage them. Because going back to like this fix-it model, there are a lot of practitioners who find a problem, dysfunction somewhere else, and I used to do this, so like, I mean, we've all done this actually, probably in this group. Yeah, there's no pain here, but it looks like this ankle isn't moving as well, so that's probably why you have back pain.
It's because what ends up happening is the ankle stops talking to the knee, which stops talking to the hip. And then the spine starts thinking that the ankle's saying something differently, which means that it's going to start to move aberrantly, which causes pain, which then leads to a leg length discrepancy, which means I need to adjust the calcaneus posterior to anterior in order to increase their ankle mobility on the contralateral side.
Yeah,
Yes.
and I'm not saying that
So
there's anything
like
wrong.
we're trying to say, giant leaps and bounds to be able to draw cause and effect. You just can't say that.
Yeah, and
What
like
was
we're not saying don't work on other body parts. Like sure, if there's some type of thing, if it's something that's going, someone's having issues and they say, well, I can't squat all the way down because my ankle feels stiff. Well, if we can find a way to make that ankle feel a little bit less stiff for them, maybe that'll help. But yeah, we're not fixing anything, and there's no data to show that anything we do with our hands actually has a long-term effect for somebody.
So
All we do is modulate pain and discomfort.
I'm going to say something, but so I don't know, a good visual for me always is if you picture like the evidence-based practice kind of Venn diagram where you have a circle saying patient preference, a circle saying clinical experience, and a circle saying research. And then we picture kind of the biopsychosocial Venn diagram. It's biology, psychology, and sociology. You got to realize that biopsychosocial Venn diagram fits in every circle of the evidence-based medicine circle. And we aren't saying, as you just said, like, look at one structure or don't look at the whole person. We're literally saying, look at the whole person and look at all of the collaborated research, not just on mechanics, but on biology, psychology, sociology, because at the end of the day, that's what's going to determine where we're going to go with things. And it's a much better predictor than my ankles miscommunicating with my hip.
Yeah. We're not looking at that stuff, though. We come from that mechanical background. So somebody who, says they were looking down at their phone a lot, and I'm not going to dive into posture a lot, but someone who is looking down at their phone a lot and they get some neck pain or they get some headaches, and they started, looking up after a little while, they started to feel better, or they went and got treated or something, and then they started feeling better after that. We know that time and regression to the mean are one of the biggest factors in someone getting better. And so, maybe we said, yeah, it must be your neck position or the fact that you have tight muscles that's causing this pain. But we never actually looked to see if maybe there was some extra stress. Maybe when they were looking down at their phone or their computer, they were studying for exams and they weren't, feeling 100% up here for that. There was a lot of stress. Maybe they weren't sleeping. So maybe those were the things that could have been the cause of that, and then they got sensitized, and then 4 weeks later, when there's no more exams or no more studying and the stress is a little bit down, it goes away. And the only thing we have to say is, well, I did it and they got better, but we know that the post hoc fallacy isn't, we can't just say that.
Yeah, I think that gets like really well addressed. If let's circle back to the rest of this paper here, because we're talking about the physical exam, and what you're saying there, Dave, is they look at what these authors really encourage us to make sure that when we're performing that physical exam, look at how the person reacts cognitively to what you're asking them to do, right? How are they processing? When you say, like, I want you to just touch your toes, like, what is their emotional reaction to the idea that you're going to make someone in pain try to touch their toes right now, right? That really matters. And then, like, if you tell someone, I want you to, like, move from a sit to a stand and then back to sitting, like, what is their, like, behavior towards that? Like, do they noticeably tense up? Do they get kind of scared? Are they looking around? Like, what's their behavior? What's their psychology towards the physical tests, right? That's how we start combining this full process. And then that kind of leads into what these authors, and I know this is Peter O'Sullivan's work in the cognitive functional therapy idea, is when you're working with someone and let's say, yeah, they had that neck pain, they were stressed and stuff, like what we can really try to work towards is like, again, the 3 pillars that CFT talks about, like making sense of that person's pain, like you just said, like explaining that, yeah, you were looking down a lot and that can put some stress on it, but what are the other stresses that are also impacting that? And then reintroducing exposure with control. I know, Elliot, you love that a lot when it's just like, how do I re-expose someone to their painful stimulus, but appropriately, right? Do I load away from it first and then start easing back into it slowly? Right? We know that that's important. If that someone has that pain, like you're saying, Elliot, rotation and extension, our job is not to encourage that person to never do that again. Our job is to encourage that person to do that again under control and without pain. And how do
At
we
the
work
right
into
time,
that? Yeah, exactly. And then finally, the last thing, like again, kind of what both you guys are saying is that third pillar here is that lifestyle change, right? And lifestyle change can happen with behavior change over a long period of time, or it can be just like what's going on in your life. Did you have a tough week at school? Did you have a tough week at work? Right? And sometimes we can help guide people towards that, and other times it just takes its own course, right? And I think if we're gonna summarize all that back to like SI pain or pelvic girdle pain, is it's like pelvic girdle pain is pain, and we don't need to treat it as a super special, unique experience unless there are some issues with like incontinence and pain with sexual activities. That's when it's appropriate to co-manage and get some people who are like trained in this. Contact your pelvic floor physiotherapist. This is their realm. It's okay to, it's encouraged to get a bigger team. But if we take that out, yeah, the SI in the pelvic area, it's pain, just like anywhere else. It's your shoulder, it's your knee, it's right.
The number one risk factor of getting pain in a certain spot is the fact that you've had pain in that certain spot before, right? But I think we know that the biggest risk factor for all of these MSK pain things is just being alive, right? It happens. We work, we do things hurt. And I don't think this should be this abnormal thing. Like a lot of us go to the gym and work out and then we deal with delayed onset muscle soreness, a day or two after. Think like it's hard to walk upstairs. But for whatever reason, that's normal. It's just because we were working out in the gym. We'll get better. We'll be built back stronger. So I'm going to keep doing this.
Whereas, yeah, Dave, no, I was going to say, we actually frame it the other way where it's good. Like exactly. I know I look forward to it. So you actually get this, we're bodybuilders where they go and get manual therapy and they like the pain experience of manual therapy. They think that's causing them benefit. So yeah, anyways, what you're saying is just what you're perceiving it to be related to.
Yeah. But like this is like a glorified thing, right? Like, yeah, delayed onset muscle soreness. That means I worked hard. That means I'm making progress. But then as soon as we have some low back pain, which is sometimes delayed onset muscle soreness is kind of a part of that too, we think it's bad and that we need to fix this and get rid of it right away. When in reality, it's just, not in all cases, but probably a good chunk of them. It's just our body saying, hey, slow down a little bit. We probably did a little bit too much, or there's a lot going on in your life right now that we just need to take that step back, dial things in, and come back even stronger than before. Because
I just want to add one thing to here, if you don't mind, quickly. Yeah. Where we always talk about in the clinic, where it's like one of the risks is temporary soreness. I know Ben probably heard this one enough yesterday with a certain assessment that was going on, talking about risk factors. But the idea of like, oh yeah, once you're done with you, like you may have temporary soreness, but that's to be expected, and that's a good thing, versus the pain they came in with, which is a bad thing. And then we have the audacity to say to them, you should probably know at this point in your life what the difference between good pain and bad pain is, right? Yeah, there's been so.
Oh man, that one.
I mean, the whole idea of nocebo in the informed consent process, that's an entirely another episode that we could get into. But let's, for the sake of not having people fall asleep on us, let's bring it back around. We'll wrap it up here.
Yeah. Like, so my final thoughts incorporating this paper into the Fix-It model, and I really encourage everyone to read it. It's not open access, but you can always email the authors or find other mediums to it. They provide a framework that shows us different risk striations, like how you categorize someone who's going to be low, medium, and high risk. But the two most important things for the low and the medium risk, which is really what we see more of. We see a lot more people who are more scared and just like frustrated with their pain experience, right? You see more of that than like someone who's coming in with like a very, very serious pathology that needs a medical referral. Is our job shouldn't be to fix them. there's nothing to fix, and there's nothing that we can fix, but we can guide people through the process. We can hold their hand through the process in a positive way, right? That's more or less what our goal should be. Our goal should be, and you guys can add in here, is to show the people that they are okay. That is number one. First things first, you are okay. Your pain is real. Your pain is a normal experience, and it's serious to you, but you're going to be okay. And then however you choose to build them up from there, like Elliot was saying before, and all of us have said before, as long as you're using the right language, the interventions probably doesn't matter that much. It matters that you're guiding people, you're encouraging them to keep active, you're encouraging them to take control of themselves, finding solutions for themselves. And then however else you choose to supplement that in, go for it.
Yeah. So that was absolutely fantastic summary of the whole paper. We will put a link to the paper in the description, down in the show notes, in the description on the video, where you can find a link. Now, if you are, like Ben said, you can email the author, you could reach out through social media and Twitter for them. Twitter is actually a fantastic way to get in touch with authors of these papers, because most authors they just want you to read the research.
They are
and of
so
course,
happy to receive an email. Yeah.
Of course, if you're a student, or if you are part of an organization, a professional association that has access to a database, you can often get access through there. But highly recommend reading this paper. It's not just about pelvic pain. You can take these principles and apply it to any kind of pain the patient is having, and truly have that patient-centered approach and help people get better faster.
Bingo.
That's it, folks.
All right. So we're gonna be calling it that, but we'll be back. We're making episodes every other sometime. So we will see you next time, or rather, you'll see us next time.